to another week. Today we're going to go over treatment, and I know we've spoken a little bit about treatment previously, but this kind of wraps up a good chunk of what I term Unit 1 of the class. So going over what common treatments do we see when patients are in cardiac rehab that they've gone through. So first, leading up to the treatments, we want to go over the basics. So what we call this prevention, what you see most patients when you take a look at their assessment, their medicines, what they've been through. We call them the ABCDEs. Awareness and aspirin and blood pressure, cholesterol, diet, exercise. A little bit more examples of the A's are antiplatelet medicines. We're going to go over pharmacological treatments in a little bit. Anticoagulants, anginal medicine, ACE inhibitors. All of these A's are really awareness, medicine, aspirin, blood thinners. The B stand for blood pressure. Again, a lot of medicines, oftentimes beta blockers. Many times B vitamins are supplemented as well. The C stands for cholesterol management, understanding where we want cholesterol numbers to be, remembering that during phase 2, we're going to send them for another cholesterol test midway through to see how exercise and behavior changes are helping their LDL levels. Cigarette smoking cessation is on there. Is that being addressed? How is it going? D is what's going on with their diet. What are our diet goals? What changes are we making in the diet? What's going on with glucose? Glucose level check, medicines, or all of those things under well control. E for exercise. Lots of understanding of what they're doing 3 days a week with you in the clinic and what is their home exercise program is looking like. And for women, a lot of times it's estrogen replacement and lots of education. We have to teach and educate and talk through risk factors and ways of healthy lifestyle living. And then there's an S for social support and stress management. So that's a lot. When you think about what is your role as an exercise physiologist, also known as a case manager in a cardiopulmonary rehab, it's making sure all of these little ends have been addressed. Everyone is feeling like their risk factors are well managed, and communicating with the physician to see if anything may change. This is a quote. I'm not going to read you this nice long quote, but we're going to spend the next couple slides reviewing what we did way back in the beginning a few weeks ago with a little bit of the pathophysiology of how this disease, what it looks like. So when we're looking at atherosclerotic plaque buildup and what we call coronary artery disease, we remember it may be silent. People may not present with symptoms. And we know that this happens. People have no symptoms or no typical symptoms because a lot of times their diabetes and high blood pressure have led to autonomic nervous system dysfunction, so they're not making those changes with the angina. So what we want to take a look at is your basic of arthrosclerosis, right? The plaque buildup, it's usually systemic from the coronaries in their heart. It could be down on the peripherals in their legs. It could be severe despite the absence of clinical symptoms. Again, not everyone may have a body that's producing symptoms, but they still could have what we know as a vulnerable plaque. Typically a non-obstructive atheroma. It's made up of fat or central lipid core with a fibrous cap and yellowish appearance. What triggers these acute coronary events? Lots of different things in life can trigger the plaque, the arthrosclerosis, to become what we call vulnerable. So changes in environmental, triggers that we're breathing in, stress, hydration, small little, any type of change in our basic homeostasis can trigger that destabilization of plaque. So when you take a look at the endothelium, right, where that damage originally has begun at, our endothelial lining, we want it to be nice and healthy to protect us from this process of happening. But during life and exposure to triggers and inflammation and risk factors, we know we end up with, as I taught you earlier, endothelial dysfunction. And these small little cellular changes is what begins the inflammatory process, and it begins this excess oxidation of our LDL cholesterol, right? The bad cholesterol, along with all these other complex biological processes. And here we end up over time, hardening of the arteries, plaque buildup, and you see this area is narrowed. So now we have reduced size of the lumen, not getting adequate blood flow, and the person commonly may present with symptoms, symptomatic, or they could be asymptomatic if they've got a lot of autonomic nervous system dysfunction. They can end up with a myocardial infarction, EKG dysrhythms, heart failure, or death can happen, right? So when you're looking at that photo I showed you in the angiogram at the last photo, they can have silent ischemia, right? No symptoms, but are ischemic, not getting blood flow, chronic stable angina, acute coronary syndromes, unstable angina pectoris, or a myocardial infarction. So when you take a look at how we define each of the ones I just listed, the silent ischemia is when there's EKG changes. So you start seeing changes, the Q wave, ST segment changes, T wave, a lot of different things in the EKG can change, even though they're absent of having any of the typical symptoms. We see this a lot with diabetes, a lot with long-standing hypertension. What happens with diabetes is autonomic neuropathy sets in, so the autonomic nervous system is no longer communicating, hey, to the body, hey, help, and you got chest pain or nauseousness or shortness of breath. Chronic stable angina happens when there are episodes of chest pain or symptoms, dyspnea, fatigue, that happen, and when we call it chronic, patients oftentimes have these symptoms at a predictable level, right? So they happen all the time. They have the same type of symptoms. They're usually relieved when they rest. So it might be they get chronic stable angina when they mow the lawn or when they walk down the driveway. So it's kind of predictable at a certain threshold, a certain level of ischemia. As they're not getting adequate blood flow, they begin symptomatic, they subside when they rest, and we call that, like I said, the word chronic. So chronic is different than the word unstable. So chronic is stable, right? It's predictable. It comes on with same symptoms, usually doing the same things. Unstable angina is it changes in intensity. It presents a lot more like a heart attack. It's prolonged. We usually can see diagnostic criteria in blood values. So with cardiac markers in the blood, you can see it oftentimes in the EKG. It is more severe, right? So it's increased in severity and intensity of this angina, and usually it needs treatment very quickly. Chest pain, so what we call the underwriting triage, let's say an emergency room physician would learn is, they're trying to figure out as much as they can, as quick as they can, the age, the cardiovascular profile, where do they go to? Were they able to sleep and go the next day to the family doctor, the GP, or did they come to the emergency room? What were they doing when it brought on? Were they active? Were they sitting? What helped it to relieve? So a whole list of questions helps the physician to figure out what to do best. Cardiac troponin is a cardiac protein, and it's mediated, the calcium-mediated interaction between actin and myosin. So what happens here with troponin is raised cardiac troponin is what is classified as an acceptable standard, a biochemical marker for the diagnosis of a myocardial infarction. So this happens in the emergency room. They're going to draw blood immediately. And what they're looking for is this excess of these troponin protein levels, CKMB levels. And depending on the value, it is going to let the doctors know how long has it been going on, do we have structural damage, what happens next. A test for a B-type natriuretic peptide, or the BNP, is primarily used to help detect and diagnose and evaluate really the severity of heart disease. So though the BNP are usually used to recognize heart failure, it's important to note that an increased level in people with acute coronary syndrome, right, the ACS, acute coronary syndrome, indicates increased risk of recurrent events. And the healthcare practitioner, this is important for them to realize that it also puts them at risk for future cardiac events. So this is, we're not doing the blood draw, but I want you to know kind of the story of what a patient has gone through. Then they're going to go through kind of diagnosing, right? So they present with symptoms, and then what are they going to do to diagnose? Many times it's going to be the EKG stress test on a treadmill. That's what your job is eventually, to run as an exercise physiologist. Or they can use other diagnostic testing. Stress echocardiogram when they don't want the person to walk or they can't walk, balance problems. And they can do more fancier, more higher price testing. I say higher price because it's definitely a higher level. They're not going to use it on everyone. More invasive testing to determine what course of treatment do they want to go through? So when they're assessing somebody who's been newly presents to the hospital, exercise ischemia, treadmill performance, they're looking at ejection fraction, they're looking in the echocardiogram for wall motion. So they're really assessing what is the outflow of blood, right? What's the cardiac output? And are there any structural problems? Are there any electrocardiogram problems? Then we get into the angioplasty that I already talked to you about. And there's a nice video here of showing you what happens in the cath lab, right? They're going to go in, they're going to inject some dye and take a look at how the blood flow looks. And the cardiologist is going to then use that information from the coronary angioplasty to determine, do we need surgical intervention? So aggressive management could require months or years, unremitting symptoms, inability to tolerate medicines, pharmacological. They may have lack of compliance with motivation. All of these things need to determine on if they're going to revascularize, which procedure are they going to use? Are they going to do open heart surgery, right, the CABG, or are they going to use an intervention, right, the angioplasty and stent, the PTCA, PCI, so angioplasty, atherectomy, which I've already spoken about. So when you think about the history of how all of this evolved, right? So I've got the kind of photo of what was the evolution of how they figured out heart surgery. I'm not going to ask you to know any of this, but I think it's a really important thing to say that way back in time, it was reported back in the 1896 was birth of cardiac surgery, where sutures could be placed in the heart. And from there, continuing information on structures between the diaphragm, the bronchi, pericardium. They were able to describe what we know as collateral circulation, right? New growth of vessels, with hopes that as they understood that our body has the ability to produce new vessels with good behavior, good exercise, good eating, that we have therefore enhanced cardiac circulation. Fast forward another chunk of years, and then we see the very first surgery done in 1962, where they took SCV, saphenous vein graft, that's from the leg, and they to the right coronary artery. So they took the vein from the leg, cut it out of the leg, used that vein, somewhat turned it into an artery, sewed it on, sutured it on into the heart to bypass the blockage that was in the person's right coronary. The person did not survive, but at least they tried this. And very quickly, more successful surgeons began doing more of this. And there seems to be a lot of kind of conflict on who and which one takes the claim. But during this short time period in the 60s, many of these thoracic surgeons and cardiologists were trying the CABG procedure and trying to really make it successful. So I've got a few different cases on here. Again, not something you really need to be super, nothing you need to memorize or know. But I think it's really fascinating. And to also know that here in Ohio, the Cleveland Clinic was one of the very most successful first procedures. And again, it was on the heart bypass machine. The heart bypass machine is how they invented this ability to bypass the blood out of the heart back in the 50s in order for the surgery to happen in the 60s. So by taking the blood out of the heart to slow the heart so they can sew the sutures on the heart is really what enabled these surgeons to figure out how to perfect this procedure. So then in the 60s, they started using this heart-lung machine. As time has progressed, new developments have happened with using a port access instead of having to saw through the sternum, do the mid-cab. They're now using the off-pump, as I told you before, suturing on those new bypasses within a beating heart, and doing better options with using the LIMA, left internal mammary artery. They're using the right internal mammary artery. With all of this changes the price. So early and mid-90s, less invasive procedures with statins and angioplasty, laparoscopic surgeries. When we talk about minimally invasive, right, there's no specific definition to what this means, but pretty much in the world of heart disease, it means they don't have to saw through that sternum. So if you're not having to go through that sternum and you don't have to use a cardiopulmonary bypass machine, it is, right, you don't have to stop the heart. They saw better outcomes. Now, not to say that all surgeons are doing this way. The way in which the surgeon is doing the bypass surgery depends on many, many factors. So whether they're using the heart-lung machine or not, it really depends on the blockages and the location of the heart. It depends on the surgeon themselves, the patient, all of these things. But again, they can do off pump where the heart is beating, or they can do the classic where it's using the cardiopulmonary bypass machine. So I've talked a little bit about this earlier, but right, using the sternotomy where they're sawing through that sternum, really getting full access to the heart, or doing a mid-cap, the lateral atherectomy is another way. When they're going to use the heart-lung bypass machine, cold cardioplegic solution is going to slow the heart, kind of freezes the heart down. So it kind of is held in this nice cold kind of chamber, right? So just kind of like a chunk of meat, right? It's kept cold. And then they can sew on the bypasses, whether it's the saphenous vein, the left or right internal mammary, and really usually get some really good patency, right? If the person abides by a new lifestyle, new diet and smoking and stress, really the life of the new bypasses could last for a long time, right? So we're seeing, patients that adhere to what they learn in cardiac rehab being successful. You've seen this photo. I've used it before in an earlier lecture, but these are all the different choices for grafts. Most commonly, they seem to love using the saphenous vein, nice big thick vein turning into the artery. And then these right and left internal mammaries are also nice good ones. Again, there's other graft choices they can use as well. So it depends on the quality of the vessel when they extract the vessel, what type of vessel they're going to use to do the surgery with. So anyways, this is what it looks like. This is what the bypass surgery looks like. It is something that I think all exercise physiologists need to have a basic understanding, because we all, like in cardiac rehab, to draw a photo like this. It is so educational if you can understand the surgical report, understand how many bypasses, where they got the bypass from, and then to take a photo and take your, red pencil crayon, your red markers or whatever, or your blue, and draw a little photo of the heart. And I know my patients over the years have said they love that photo and they put it right on their fridge, because finally the patient understands what a bypass means. So again, we're not doing the procedure, but I want you to be able to walk through what happened to them and draw them a photo of how many bypasses, where these bypasses went. Draw in the blockages on those right arteries, right, left, circumflex artery. Show them where those blockages were. The more they understand what happened on the inside of their body, usually what we see is the better adherence we have with the behavior changes. These are all fancy tools we're not using, but this is, if you get lucky enough to go and be able to observe a surgery, this is what they commonly look like, right? This is what we're going to hold open, that chest wall from to get full access to that heart. The cardiopulmonary bypass machine does just like what I said. It's rerouting the blood away into the heart-lung machine and back into the body without permitting the heart to be beating in their hand. This is the big complex cardiopulmonary bypass machine, what it looks like. So I think it's a fascinating surgery. I know many of our students, quite a few of you in this class already, have been able to witness an open heart surgery. Some of the problems that happen with the cardiopulmonary bypass machine, it's very good, it works. However, they do often see some negative consequences with inflammatory response, strokes, bleeding, issues with irregular heartbeats. So, as someone comes off of open heart surgery, they are watched very closely in the CCU, the coronary cardiac unit in the hospital, to make sure that they're able to resume a functional heartbeat and be able to be discharged. CABG procedure without using the bypass machine, they avoid having blood transfusions. It is reduced cost, blood clots. So they do see a lot of benefits if the surgeon's able to do the surgery without using the bypass machine. So again, this is just a nice simplified view of what it looks like, right? So we've got these occlusions, all of these blockages. You would draw in the blockage, and that's what it looks like, right? The narrowing of that arthrosclerosis. And then here we've got 1, 2, 3 bypasses: a saphenous vein, another saphenous vein, and this is the left internal mammary artery that comes off the subclavian. So this is what we call a triple bypass, 1, 2, 3. So they would have at least 3 major blockages, and you'd read this in cardiac rehab, you're going to read this in the surgical report, and they'll tell you what tissue or what vessels they use to make the new bypasses. This is what it looks like in real life, right? The heart with the bypasses that are right on there. I've got a nice link, and that's going to be your homework this week to go find your own link, but I encourage you to watch these links. They just make all of this make more sense. If they're going to do a mid-cab, they're going to be relying on using from that subclavian, the left internal artery, the left internal mammary artery. I'm going to cut one of that side off from the inside of the chest wall and suture it over to the heart. And that is a nice procedure, decreased hospital stay. So minimally invasive cardiac surgery, lots of different ways that they can do this. It is, again, not what we're not doing the procedure, but it's something I want you to be able to answer questions on the exam of being able to walk through. What do you tell somebody? I want you to be able to understand when you're working with training, exercise, training somebody who's been through the surgery, you have a little bit of a stronger understanding of what all this means. So again, minimally invasive is they're going to be able to get access without going through that sternum, depending on where the bypass is. So, right, like minimally invasive, being able to go in there, get access to the heart and do the bypass. Again, off pump allows the surgeon to sew that bypass onto a beating heart. Lots of advantages. If they're the ideal patient, the blockage is in the right location, all of these things are going to make the mid-cab beneficial. Right? So again, this is just such an incredible procedure that's why I kind of like you to be aware of this. One of the biggest questions patients often have is the patency of the graft. Is they feel so good, right? A few weeks after open heart surgery, they're getting more blood flow, they're oxygenated, they feel great. How long are these going to last? Are they going to have another 60 years of life? No, not necessarily. These grafts can become blocked very quickly, right? Within a couple of years if they go back to their old life. So anyways, here's now a link to the offbeat, so the beating heart. What research is going on right now are just more ways of anastomostic devices, so ways of suturing these vessels onto the heart, different ways of doing the intervention, different ways of getting access into the heart, and different tools being used. That's open heart surgery. When you look at angioplasty, so percutaneous transluminal coronary intervention, it began in the 70s, so after open heart surgery. And the history with this is, I think I mentioned this in an earlier lecture, was, happened in Germany, and, all of this trial and error happened, and pretty much realized that once they had this blockage in here, right, so this blockage, they could put a balloon in there and then deploy a stent, right, this little metal stent, and that stent's going to hold open that artery. So I'm not going to read you through these slides because, again, we're not doing this, but that small little catheter is guided up and through the aorta all the way down to where it needs to go, right? They got it all the way into where the blockage is. Once they've got the guide wire right in here to where the blockage is, they're going to inflate that balloon, right? Once that balloon is inflated, the person does not feel good, right? Because what's happening is that balloon is pushing the fat to the sides of the artery. And they're only under local anesthetic. They're going to be able to talk to the cardiologist throughout this procedure. They're going to inflate that balloon, push that plaque to the sides of the wall for several seconds, and then take the balloon back out. That was once what they did back through the 90s. They were only using balloons, and then they started deploying the stent, and obviously the stent gave a better longevity of being able to hold, act like a little wall in that artery to hold the fat where it needed to go. So angioplasty is going to be followed up with a lot of pharmacological agents. It's predominantly going to be things that thin the blood to avoid thickening, fibrin, all of those kind of platelet inhibitors to help. So when you think about angioplasty, recurrent stenosis is going to treat most commonly 3 to 6 months post angioplasty is when, if it's going to restenose, that's really when you really want to watch it. Really watch for angina, look for EKG changes. And you've seen these slides before. I love showing these slides where it's very faint, right? The blockage is in there, and then post intervention, you see a nice black line. So the ischemia is going to be subsiding because you're getting adequate blood flow. The advantages of the stents is that, again, they're going to hold that bypass, hold the blockage to the walls. They're made of various types of metals. They are now, stents are covered in anticoagulant stuff, so medicine, so the kind of medicine, the heparin or the blood thinner that they would take, but now the stents themselves are covered, so they're releasing to help minimize blood clots that can form and develop over time. So anyways, I think you get the gist of what a stent is and what an a percutaneous transluminal coronary angioplasty is, and all of these different methods of going in and doing atherectomy and removing the blockage. So there's lots of other things that are going on, lots of future advancements. We could spend time reading journal articles of what is the newest research going on in stents and interventions, but that again is not the focus of this class. I want you to understand your job as an exercise physiologist working with cardiac patients. But there is lots of new interventions, very innovative stuff going on. What I want you to be able to do from this lecture is be able to talk through, if I ask you, explain to your patient what it means to have a stent put in. How would you be able to describe the procedure? Or if somebody had an open heart surgery, CABG, explain to the patient in your words, write out how you explain bypass surgery. So that's kind of the gist of all of this, is just being able to understand the process in itself. So what I want you to do this week is I want you to find your own video, a really cool video that you like. I want you to post it to the discussion board. I want you all to spend some time watching and learning about cardiac treatment. You are going to post your link by Wednesday. And then all of you need to respond to each other and watch and learn together. So it's not monotonous of me just lecturing at you.